Welcome back to Clinical Insights, everyone. Today, we're diving into a topic that, honestly, often brings a lot of anxiety, not just to patients, but sometimes even to medical students. Dr. Aisha, you know the scenario. A young, bright medical student, maybe 22, finds a lump in her breast. She's instantly terrified, thinking the worst.
Absolutely, Professor. It's a classic presentation, isn't it? The sheer panic that can set in, even for someone who intellectually understands anatomy and pathology. But then, you, as the experienced clinician, examine her, move the lump, and it literally slips away under your fingers. That incredibly mobile, firm mass. The classic breast mouse.
Exactly. And in that moment, the immediate relief on her face is palpable. It's a powerful reminder that not every breast lump signifies malignancy. But, and this is a huge but, every single lump demands a disciplined approach. We're talking about the triple assessment, and we'll delve deep into that today. Our aim is to really demystify these benign breast conditions and infections.
It's so crucial, Professor, because while malignancy is always the fear, benign breast diseases are far more common, and understanding them helps us provide not just effective care, but also much-needed reassurance. Today, we're going to help our listeners, especially students and junior doctors, understand the concept of ANDI, or aberrations of normal development and involution. It's such a foundational framework.
Indeed. We'll differentiate between cyclical and non-cyclical mastalgia, which is breast pain, discuss how to manage acute lactational mastitis and breast abscesses, and then touch on how to evaluate various types of nipple discharge. It's a comprehensive look. So, let's start with the basics, Dr. Aisha. When we talk about benign breast diseases, what's the fundamental takeaway?
The fundamental takeaway, Professor, is that they are incredibly common, much more so than malignancies. And what's fascinating is that most of them originate from a specific part of the breast, the terminal duct lobular unit, or TDLU. It's really the workhorse of the breast, isn't it?
It is. The TDLU is where a lot of the action happens, both normal physiological changes and pathological ones. And the ANDI framework you mentioned earlier, it's revolutionary in how we view these conditions. Instead of seeing them as distinct diseases, ANDI encourages us to see most benign conditions as minor variations of normal physiological processes. It takes away some of that pathology fear, doesn't it?
It completely reframes it. It moves away from a purely disease-centric model to one that acknowledges the breast's dynamic nature, its constant changes throughout a woman's life cycle. So what are some of the most common benign conditions we encounter, and what's behind them?
Excellent question. Let's start with our breast mouse, the fibroadenoma. This is essentially a hyperplasia, an overgrowth of a single lobule. It's incredibly common in younger women, typically between 15 and 25 years old. Think about it. A young woman, hormonal changes, and this localized overgrowth. It's often seen as a response to estrogen sensitivity.
And the clinical presentation really matches that pathophysiology, doesn't it? It's usually smooth, firm, and as we said, highly mobile. Patients often describe it as feeling like a marble or a pebble that just rolls away. What about breast cysts, Professor?
Cysts are interesting because they typically occur at a different stage of life, usually during the involution phase, roughly ages 35 to 55. As the breast tissue naturally undergoes regression and changes, some ducts can become blocked or dilated, leading to fluid accumulation. They're often described as tense, fluid-filled sacs. Sometimes patients even feel multiple of them, giving a bag of marbles sensation.
That's a great way to put it. And then we have mastitis, which is often associated with a very specific scenario, isn't it?
Indeed. Mastitis is usually an infection, and in lactating women, it's almost always due to Staphylococcus aureus entering through a cracked nipple during breastfeeding. It's incredibly painful and distressing for new mothers. But remember, mastitis can also occur in non-lactating women, though less commonly, often linked to periductal mastitis or issues around the nipple.
And the key to that is often distinguishing between simple engorgement or blocked ducts and actual infection, which requires antibiotics. What about duct ectasia? I know that's another common one, especially in a certain demographic.
Duct ectasia. This is where you see a dilatation of the major subareolar ducts. It's often associated with smoking. The inflammation and damage from smoking can lead to changes in the ducts, causing them to widen and sometimes fill with a thick, sticky discharge. It can be quite troublesome and recurrent.
So we've talked about the underlying pathology. Now let's move to how these conditions actually present. What are the common symptoms patients report, and what do we look for on examination, Professor?
Right. The cardinal symptoms, broadly speaking, are pain, or mastalgia, which we'll break down, then lumps, which we've just discussed, and finally nipple discharge. For pain, it's crucial to ask if it's cyclical, meaning it fluctuates with the menstrual cycle, or non-cyclical. Cyclical pain is very common and often linked to hormonal changes. Non-cyclical pain can be more concerning, sometimes localized, and might warrant further investigation.
And the nipple discharge, Professor, can that give us clues as well?
Absolutely. The character of the discharge is vital. For instance, in duct ectasia, it's often greenish or brownish, thick and sometimes sticky. If a patient reports bloody nipple discharge, our antennae immediately go up. While it can be benign, like an intraductal papilloma, it always needs thorough investigation to rule out malignancy. It's a red flag.
So the color and consistency can really guide our differential. And on physical examination, what are the classic signs for these conditions? You already mentioned the fibroadenoma as smooth, firm, and highly mobile.
Indeed. For an abscess, which often follows mastitis, you'll see the classic signs of inflammation: tenderness, heat, redness, and crucially, fluctuance, meaning it feels like there's fluid underneath, almost like a localized sac of pus. With a cyst, it will feel tense, smooth, and often well-defined, sometimes even appearing with a halo sign on imaging due to surrounding compressed tissue.
So the physical exam, combined with the patient's history, gives us a strong starting point. But for any lump, or indeed any concerning breast symptom, the triple assessment is non-negotiable. Can you walk us through that, Professor?
The triple assessment is the cornerstone of breast diagnostics. It's a three-pronged approach. First, you have the clinical examination. That's the history taking and the physical examination we just discussed. Second, imaging. This depends on the patient's age. If they're under 35, an ultrasound is usually preferred because their breast tissue is denser, and mammography is less effective and involves radiation. For those over 35, mammography becomes the primary imaging modality, often supplemented by ultrasound. And the third, equally vital component is pathology.
Pathology is where we get the definitive diagnosis, isn't it? Whether it's a fine needle aspiration cytology, or FNAC, or a core biopsy.
Precisely. FNAC is less invasive and can give us a quick cellular diagnosis, especially useful for cysts where aspiration might even be therapeutic. But for solid lumps, a core biopsy is often preferred because it provides tissue architecture, which is crucial for distinguishing between certain benign conditions and malignancy. If all three components of the triple assessment align and indicate benign disease, then you can confidently reassure the patient, referring apparent be humans forgotten.
And what about nipple discharge evaluation? Is it also part of a triple assessment type approach?
It's a slightly modified approach. We'd still start with a thorough clinical history and examination. Imaging, especially ultrasound of the ducts, is key. But for pathology, we often send the discharge itself for cytology and culture if infection is suspected. If there's a specific duct consistently producing discharge, a microductectomy or excision of that single duct might be both diagnostic and therapeutic.
That makes sense. So once we have a diagnosis, how do we typically manage these conditions? Let's start with conservative approaches.
Conservative management is often the first line, especially for something like a simple fibroadenoma that's less than 3 centimeters and entirely benign on triple assessment. Reassurance is paramount. We observe it, perhaps repeat imaging in 6 months to ensure stability. For mastalgia, or breast pain, especially cyclical pain, NSAIDs can be helpful. Some patients also find relief with evening primrose oil, though the evidence for that is a bit mixed. It's generally safe.
So for small, uncomplicated fibroadenomas, watch and wait coupled with reassurance. What about symptomatic cysts?
Symptomatic cysts are usually aspirated. If a cyst is palpable, causing pain, or large, a fine needle aspiration can relieve symptoms immediately and provide fluid for cytology if there's any concern. It's often very satisfying for both patient and clinician to see the cyst disappear right there.
And for abscesses, Professor, that's a different beast entirely.
Indeed, a breast abscess requires more active intervention. The standard approach used to be incision and drainage, surgically opening the abscess to drain the pus. However, increasingly, ultrasound-guided aspiration is being used. It's less invasive, can be done under local anesthetic, and often achieves good results, sometimes requiring multiple aspirations. Of course, antibiotics are essential alongside drainage.
That's a good point about minimizing invasiveness where possible. What about surgical options for nipple discharge when conservative measures aren't enough?
If you have troublesome nipple discharge, especially if it's recurrent or the patient finds it very distressing, there are a couple of surgical options. One is Hadfield's operation, which is a total duct excision for generalized duct ectasia or discharge from multiple ducts. It essentially removes the major ducts behind the nipple. If the discharge is from a single, identified duct, then a microdicectomy, the excision of just that single duct, is a more targeted approach.
So tailored surgical options depending on the extent of the problem. Now, no discussion of conditions or treatments is complete without touching on complications. What are some of the potential complications of these benign breast diseases themselves?
Good point. For diseases like mastitis, the primary complication is the formation of an abscess. If an abscess isn't treated effectively, it can lead to chronic infection or even a fistula, especially in cases of periductal mastitis, sometimes called Zuska's disease in smokers. That's a persistent tract from the skin to the duct system, which is very difficult to treat. But beyond the physical, we must acknowledge the huge psychological distress and cancer phobia that can accompany any breast lump or symptom. It's a massive part of patient care.
That psychological aspect is so important, Professor. It's not just about treating the lump, but also addressing the fear. And what about complications from the treatments we've discussed?
Even with benign conditions, treatments aren't without potential issues. Any surgery, even minor, carries risks. Scarring is a given, and sometimes that scarring can be unsightly or cause discomfort. Fat necrosis, a lump that forms due to damaged fat tissue, can sometimes occur after trauma or surgery. And then there's always the possibility of recurrence, especially with cysts or some fibroadenomas, which can be frustrating for both patient and clinician.
Recurrence can certainly be a challenge, requiring ongoing vigilance. Professor, before we wrap up, what are some of the absolute pearls or key takeaways our listeners, especially students preparing for exams, should commit to memory?
Excellent point, Dr. Aisha. For exam pearls, remember this. A fibroadenoma is the breast mouse because of its extreme mobility. If you see bloody nipple discharge, the most common benign cause is an intraductal papilloma, but always rule out malignancy. Don't forget Mondor's disease, which is thrombophlebitis of the superficial veins of the breast or chest wall. It presents as a painful, cord-like structure, and if you encounter a fibroadenoma that's larger than 5 centimeters, that's classified as a giant fibroadenoma, which might warrant excision even if benign, due to its size and potential for causing deformity. And finally, ANDI, aberrations of normal development and involution, is the preferred modern classification for benign breast disorders. It really encapsulates our contemporary understanding.
Those are fantastic, Professor, incredibly high-yield points. They really tie everything together from etiology to clinical presentation. So to summarize, what's the overarching message about benign breast disease?
The summary, I think, is a balance of vigilance and reassurance. While the risk of malignancy is genuinely low in many of these conditions, the triple assessment remains the non-negotiable standard of care. We have to be thorough, but we also have to communicate effectively, alleviating patient anxiety. Understanding these benign conditions empowers us to do both, and that's truly good medicine.
A perfect way to put it, Professor. It's about educating ourselves and our patients to navigate these common presentations with confidence and compassion. Thank you for another incredibly insightful session.
My pleasure, Dr. Aisha, and thank you all for joining us on Clinical Insights. We hope this episode has shed some light on the often misunderstood world of benign breast conditions. Stay vigilant, stay informed, and we'll catch you next time.